So it's about toracoaddominal aortic aneurysms. Probably, I think it's the intervention on a human being that has the highest impact on physiology. And you are working on the cardiac part of the body, the pulmonary system, the vascular system, the neurological system, not only peripheral, but also central neurologic. So if you have troubles, the impact on the patient and on his well-being afterwards is tremendous. So this makes toracoabdominal surgery very interesting, very demanding, not only for the surgeon but also for the team. And that's what I want to emphasize, is that you cannot do this by your own. You have to be able to rely on your anesthesiologist who are there, who is taking care for the patients for every aspect, so that you can, as a surgeon, concentrate on the technical aspect, and as well as the perfusionist, because there's an interaction. If one of these three parties is well, let me say, not active involved, you get into trouble. So the first question that you can ask is there an operative operation? Because sometimes we see patients with the aneurysms of, the question was asked this morning, 83 years old, I can't remember exactly, and ascending aneurysm of 4.9 centimeters, stable for a few years. What should you do? 82 years. Probably I would do nothing. I would just control the patient. But the most crucial question is, should you go for an operation, and when should you go for an operation? And is the patient able to undergo this enormous surgery? Because if you look at the hospital mortality in the hospital, you see that it's depending on the type, but don't forget that it can be higher than 10%. 1 out of 10 patients die during their hospital stay, even today. So before saying yes to the patient, you should be able to reduce the risks as much as possible. And you see it here once again in this. There was a meta-analysis, and what is very important is if your volumes in your center are increasing, mortality is really decreasing. So there's a link, a direct link between the experience of the team and the lower mortality. And this is probably the most difficult question to answer. There is now this patient on the ICU with this esophageal fistula, aortoesophageal fistula. And you can operate on every patient. There is no question about that. You can do stupid things, but sometimes you have to say no. Sometimes you have to say no to the family, even if you know that he's going to die within the first 84 hours. So coming back to the sizing, it's important that we speak the same language. It's important that we divide the aorta in different segments. You can give it a name, or you can give it, now there are numbers, for example in the arch, 1, 2, 0, zone 0, 1, 2, 3, and it goes down. I like more to talk about the description of the aorta, because it's more direct. If there are no symptoms, we try to prepare the patient. We will do some examinations to see if the patient can undergo surgery, and which are our criteria. Size criteria: 6 centimeters for degenerative, and if there is a connective tissue disorder, 5 is the maximum limit. But of course you have to individually look at the patient. Is there an age criterion? Is there a level that you can say, now I'm not going to operate above 80, this kind of surgery? I would say no. If the patient is 81 and is quite active, and there are no contraindications, except his age, well, I think you should just proceed with doing what's the best for the patient. Of course, if there are symptoms, size doesn't matter. You just go for immediate surgery. And this is just to show you an example, sizing is not so easy because if the aorta dilates, it becomes longer. And if it becomes longer, it will kink. And if it kinks, you get in a transverse plane an oval. And if you have an oval, you have a short axis and a long axis. What is your size criterion, the short or the long one? It's not the long one, because then you can measure here, for example, 10, while the real diameter might be only 5. So maybe this is not an operative indication yet, because the size is not 10 centimeters, it's 5 centimeters. As I said, we try to prepare the patient. And how do we do that? We have a complete list with cardiac investigations. For example, should you do coronary angiography? I think no. But if the patient has a history of myocardial infarction, if he has had a stent in the coronary arteries or a cabbage, then of course you should do it. Spirometry, maybe pneumologists might question the risk of doing forceful expiration and inspiration with an aneurysm of 10 centimeters. And some pneumologists refuse to do it. I think if you do it under controlled blood pressure, there is no risk. I've never saw problems with that. I don't know what this red line is.
Yeah, because it's a touch screen.
It's on the screen.
If you put the finger here, you can.
Yeah, so we find other things that are important, neurological evaluation. Of course, the patient should be free of infection if possible, because a lot of patients are smokers. It's obvious that you make also a status of the peripheral arterial situation.
Mark, sorry. We always, for our patient, perform coronary angiography or CT scan.
Well, I think it's not a bad idea because, as I said, a lot of patients are smokers, they have hypertension, and they have coronary artery disease associated with their aneurysm. So maybe in more than 60% you will find something that is crucial to treat before, because if you find pre-vessel disease, it will be treated first for the heart and then for the aneurysm. This is just an example of a very large aneurysm. Then the types, it was all described in the 70s by Stanley Crawford. And you know the 4 types, of which type 2 is the most extensive one, starting at the level of the left subclavian artery and sometimes going up to the iliac arteries, but anyway below the renals, because the other ones are more limited. This is the 6th intercostal artery, so it starts type 3 below the 6th, and type 4 is in fact an intra-abdominal aneurysm, but since the approach is the same as for the other ones, low thoraco-phrenolaparotomy, it's classified under the same umbrella. And Hazim Safi has described the type 4, which is a combination of type 3 on the proximal part and type 1 on the distal part. It's important to describe the type because in your operative notes you should be able to distinguish between all the different types. And then, very important is to determine an operative strategy. How are you going to tackle the problem? Are you going to use extracorporeal circulation? Are you going to use simple cross-clamping? Are you going to use left heart bypass? Are you going to use a deep hypotherapy? The first technique was used in the 70s, in the 80s, in the 90s, and then it disappeared completely because the incidence of paraplegia was too high. And also the incidence of other organ problems, because once you put 2 clamps on the aorta, you get ischemia of the guts, of the renals, and you have a lot of problems. The passive gut shunt was used until 2000 and with quite good results, but not for toracoabdominals, only for descending thoracic aneurysms. And then the rest is ECC. eventually with deep hypothermic circulatory arrest, left heart bypass, and of course the endovascular repair, which is now exploding and changing the operative scope. Simple cross clamping, very simple. 2 clamps on the aorta resect the pathology in between, but you see after 30 minutes the increase of neurological spinal cord problems. And that was the reason why it was abandoned in the 80s, late 80s. The God shunt, as I told you, it's a passive shunt. It's not an active shunt. You cannot control the flow through the shunt. And it's inserted in the ascending aorta or in the arch, like you see there, and the other side, somewhere in the peripheral arterial circulation. The results for descending thoracic aneurysm were very good, but they had a lot of problems with bleeding due to the tearing of the entrance of the cannula. Because very often patients with aneurysms of the descending or toracoaddominale, they have also aneurysmatic diseased ascending aorta. So if you start putting purse strings and at the end you remove it, you can end with disasters. So that's why it was abandoned. Extracorporeal circulation, well, today we use it because it was impossible to use left heart bypass. But we normally restrict this technique if the distal aortic arch is involved, because then clamping of the proximal side is impossible, and you have to do open proximal anastomosis. If the patient will not tolerate only a right lung ventilation, which is sometimes the case, and if there is a very huge aneurysm so that you cannot safely enter the chest, and maybe then it's better to start extracorporeal circulation via the groin, cool and open the chest first. But in principle, we stay with left heart bypass. And left heart bypass is a multimodality tool that you have to use together with the other things that are indicated on this slide. Csf drainage, very important. No drain in an elective case, no surgery. It's as simple as that. Passive hyperthermia, you get it for free. The patient cools down automatically to 32 degrees or even lower, and you have to rewarm a bit. Of course, sequential clamping, you start isolating segments of the aneurysm and you go down or from bottom to top. And then a big discussion, should you reimplant intercostal arteries, yes or no? Even today, this answer is not answered clearly, and most surgeons will still rely on reimplanting big intercostal vessels in the area between T8 and L2, because that's the area of which we know that the Adamkiewicz or the major radicular artery originates. And if you do not reimplant it and you get troubles afterwards, you can shoot yourself. So the left heart bypass is a very elegant system. You drain arterial blood, oxygenated blood from the left heart. Initially, we did it from the left atrial appendage, like it's indicated here. But you know that the left atrial appendage is a very fragile structure. It bleeds easily. If you touch it and you put a purse string, the patient gets atrial fibrillation, and the hemodynamics may drop, and you get into trouble. So the advice I can give you is stay away from the left atrial appendage and use the left pulmonary vein, which is easy to reach and easy to cannulate. You have to be careful that you don't open the left side of the heart and suck in air, because if the patient is underfilled, it can happen. And then you drain the blood through a centrifugal pump, and it's re-entered into the arterial circulation below, mostly the femoral artery, the common femoral artery, but it can as well be the aneurysm itself. And it gives you the opportunity to perfuse selectively the renal arteries or the intestinal arteries. It's not obligatory, but you can do it. That's the visceral perfusion is an alternative. But this is the basic setup that I like most. So the advantage is that you do not have to give heparin. I'm cheating a bit. You give some heparin, about 5,000 units, but your ACT is kept between 180 and 200 in the ideal situation. Not higher, not lower. You can control the optimal. You can control hemodynamics optimally. Yeah? If the perfusionist reduces flow, the proximal arterial pressure will increase. But he can decrease flow, he can increase flow, so it's an active system, and that's why you have to interact continuously based on distal pressure and proximal blood pressure. It allows for rewarming, since there is a heat exchanger that is built into the circuit, and it allows you also that you monitor the spinal cord with evoked potentials, of course. Or now the non-invasive NIRS, visceral perfusion, I said it, and the most direct consequence of using left heart bypass is that you reduce the ischemia of every organ, especially of the spinal cord. So here you see again now we should try to put, yeah. So left heart blood, arterial blood, is reinfused into the distal system once you clamp the aorta, and then you put your clamps somewhere in between. And mostly we start depending on the origin of the aneurysm, but you see that it can be over the left circulating artery or in between. You transect the aorta right over there so that you have a cuff that you see the back side of the aortic wall, because the esophagus is close there. Mostly we choose an intermediate clamping place at the level of T6 in the middle of the thoracic area, then T12, and then depending on the extent of the aneurysm, either below the renal arteries or even to the iliacs if the aneurysm extends to the common iliac arteries. So here again, I'll show you the basic setup. Left atrium, left pulmonary vein, or proximal aorta. That's the easiest thing for the perfusion, because the system is pumping automatically by the heart. Then here is a bag with the 3 liters of fluid and the 5,000 units of heparin, which I told you. There's a bubble trap, which we should try to build in tomorrow, I think. And then the pump, the heat exchanger, and the blood is reinfused into the left common femoral artery, iliac artery, abdominal aorta, or the aneurysm itself, as I said before. And by using this, you can reduce neurological deficits from 21% to 3%, simply due to the use of left heart bypass. And this has been shown by Hazim Safi a long time ago. So to summarize the benefits: no heparin, optimal organ protection. You can combine with CSF, of course. You get no damage of the blood compared to deep cooling or roll-up pumps, visceral perfusion, rewarming, optimal control of hemodynamics. There are drawbacks. If you don't care, you don't mind, you will, and you enter into the left atrial appendix, you get atrial fibrillation. You can have bleeding problems from your cannulation side, and it requires an optimal interaction between surgeon, perfusionist, and anesthesiologist. Air in the left heart is a dangerous thing, and you have to avoid it. I told you already that you have to keep the ACT around 200, 180, 200. The exposure is typical thoracocranial laparotomy. In the beginning, we did this, and then almost an angle of 90 degrees, but we had some wound problems, healing problems at this angle, so now it's more curved, more oblique. 2 fingers below the scapula point, and in the middle of the spinal, the processus spinosi, and the lateral side of the scapula. So So it's important, if you see this, that the drain should be draped right over there and not right over here, because otherwise you have to restart at the. So the pillars of organ protection in this kind of surgery is reimplantation of critical intercostal arteries, the hypothermia, and the spinal cord drainage. I don't believe in evoked potentials, but I'm willing to argue with you if someone of you says I'm a strong believer of this technique. There are too many false positives and false negatives. There are no criteria yet. The big defenders of this methodology, they have written in editorials that there is a lack of methodology of this technique. So I think it's too early to say that you should absolutely use this evoked potentials. Of course, you don't have to waste time. You have to keep every clamping period as short as possible, and that's, again, that is very important. You put a clamp on top of the aorta, in between. You put stay sutures on the wall, put retraction clamps on it, open the aorta, oversew intercostal arteries in the upper segment, reimplant them in the critical segment, and it's always the same. There's people who the assistant who takes the sucker is a very important person, because if he's asleep and he doesn't suck where the surgeon is working, you cannot see anything, and you lose a lot of time. This is not new for you. This is known. The spinal cord perfusion pressure equalizes the systemic mean arterial pressure minus the CSF pressure. So the CSF pressure is the counter pressure. If you keep it low, you get better perfusion of the cord. And this equilibrium you should keep always in mind. If the operation takes long, the patient gets a lot of volume and he will become edemous. You can see it if you do a transperitoneal approach. You see it in the guts. They get swollen, and you are fighting against the guts. But you also see it in the face. They get swollen lips, eyelids. So there is in the CVD arises. So there is indeed this equilibrium that should be kept in mind, and so we try to lower the CSF pressure, because sometimes this spinal cord perfusion pressure, imagine in situations where you have a CSF pressure of 40, which is very high, of course, and you lose blood, and your arterial blood pressure goes to 40, lowers to 40. You get zero perfusion of the spinal cord. In normal conditions, arterial blood pressure 120, CSF pressure lower than 10, 20, you get nice perfusion of the spinal cord. But if you lose suddenly a lot of blood and you don't drain spinal fluid, you get in this situation with no perfusion of the cord. So I want to illustrate this again by this thing. You all surgeons know the Monroe-Kelly principle. Everything what is in the brain or in the spinal canal, it's only blood, CSF, and neurological tissue. And these volumes are kept constant. This is the principle of CSF drainage in traumatic cerebral patients. But if your spinal cord becomes bigger because of the edema, you cannot change the blood. But you can drain here the surrounding cerebrospinal fluid in order to keep the perfusion optimal. So I'll show you this now. Then you drain, and you get swelling of the spinal cord. You should drain more. You should start drawing. I said before, no drain, no surgery. It's very elegant to put the drain before the evening before surgery, because sometimes you get blood and you are a bit anxious to continue because the patient is asleep. Did I damage something? Yes or no? If he's awake in the evening before, you are sure that you didn't damage anything. So bloody tap means in some centers that you postpone surgery. There was a time that we used double drain, but we had problems with that, with bleeding, intracranial bleeding, because we drain too much in a limited amount of time, and you get, because it's like sucking on the brain tissue when it comes down. You get tears of the blood vessels into the meninge, and they tear, and you have a very bad situation. So bloody tap, no surgery, clear CSF, you can continue. I told you this. This is the protocol, less than 10 millimeters. The evening before surgery, keep the drain in for 3 days on the ICU, and drain maximally 20 cc's per hour. There are now these automated systems, which are very elegant. We have never used it, but I think it's maybe we should think. Ah, okay. So you are used to use it, and I think it's beneficial. CSF drainage has some risks of leakage, but you can always solve it with a blood patch. This is the most dangerous and feared complication, with a mortality of more than 50%. Meningitis, headache, fracture catheter, we never had it, but theoretically, the percentage is low, 1.5%. Then the evoked potentials, two types, motor evoked potentials and somatosensory evoked potentials. You see them illustrated on both sides. In somatosensory evoked potentials, you give an electrical stimulus on the leg, and it's captured on the brain with electrodes. And with MAPS, you do the reverse thing. You give an electrical stimulus on the brain, and it's captured on the nerve in the leg. Of course, these neurological tracts cross the midline, so we should be aware of that. And it's illustrated here that there's this crossing that you know from anatomy. So it's always on the other side that you get the answers. It looks a bit like this, but well, that doesn't matter. Here you see an example of a motor evoked potential that is disappearing in time, and something is done here, like a reimplantation of an intercostal artery, and you see that gradually in time the amplitude reappears and increases and becomes normal compared to the previous one. So that's what I said. Evoked potentials certainly have a benefit that if they disappear or decrease, that you can discuss with the anesthesiologist and perfusionist to increase the proximal and the distal perfusion pressure, to drain more CSF. And as a surgeon, the only thing you can do is reimplant intercostal arteries if they are available. If they are not available, you cannot do anything. But as I said, there are still technical problems. You have to rely on technical personnel. There are the volatile anesthesiological gases which have a negative impact on the amplitude. So you have to adapt your anesthesiological protocol completely. And you have false positives and negatives, and the criteria is 50% dangerous, decrease in amplitude. Is it 60? Is it 70? Nobody knows. Now, a new concept introduced about 10 years ago by Randall Breed from New York was the collateral network. The spinal cord is surrounded by a lot of small arterial collaterals that gives blood to the spinal cord. And the input of this collateral network is from above, the circulating artery, the vertebral artery, of course the intercostal arteries, and from below. This is often forgotten, but they are all very important. So that's why your distal perfusion pressure should be high enough, not 50, but at least above 70 or 80. This is why your proximal perfusion pressure should be high enough, and this is why the surgeon should try to reimplant intercostal arteries. So in reality, it looks a bit like this. We will never, this is a drawing from Joe Coselli, we will never open the aorta from top to bottom. We will always clamp in between so that the lower part is still perfused and not ischemic. We will start, like I said before, by transecting the aorta, making the proximal anastomosis. In this area, intercostals doesn't mean anything, you can just oversew them. But if you do the lower thoracic part, because this is celiac trunk and superior mesenteric artery, I like to have a clamp here. If in this segment there are open big intercostal arteries, we will try to reimplant them and reperfuse them, of course. It's a post-dissection aneurysm, so the intimal web is resected, and this gives me the opportunity to discuss about endografts in toracoabdominals, and certainly in post-dissection. Those of you who have seen post-dissection aneurysms from inside, like today, these flaps are very complex. They don't follow a straight curve. They twist to right and left. You get thrombosis in one lumen. Sometimes they split up. You have 3 channels. They go into intercostal or renal arteries, and they continue in these vessels. I think endoprosthesis in chronic post-dissection aneurysm is a very tricky thing, but I'm aware that some big they are doing it, and with not bad results. In Paris, they are doing good jobs, but that's also the reason why open surgery is disappearing gradually, and we get more complex cases, redo cases, and that's why it's also more difficult to train people in this kind of surgery, because even for the staff members, it's becoming sometimes a rarity to do this kind of cases. So let alone to train young surgeons. Here you see the setup with the perfusion of the visceral arteries. Delayed onset paraplegia is a topic that last 5 years has become more and more in the literature, and I think nowadays 50% of all paraplegias is late onset, and late onset paraplegia can be avoided by keeping your protocol. It's written here, the proportion of late onset cases is increasing. And then what should you do if you have a patient on the ICU who is awake and he could move his legs, and suddenly 1 hour later he's not able to move the legs anymore? Here it's written, it's the protocol from Tony Estrella from Houston. If the drain is already removed after 3 days, you have to reinsert it immediately. Of course, you should optimize and elevate the proximal arterial blood pressure, optimize the oxygenation. If the patient has problems with the ventilation, maybe he should be ventilated. You should optimize the cardiac rhythm, because sometimes it happens, it starts all with atrial fibrillation, and then you get this low blood pressure, bad oxygenation, and no more mobility in the legs. Hemoglobin should be optimized, and this is discussable, intravenous steroids. Then another topic besides the spinal cord protection is the renal protection, because if the incidence of acute renal failure varies depending on your definition. If you use dialysis dependent acute renal failure, it's about between 1 and 10%. But if you use other criteria, it might go up to 30%. And if the patient gets acute renal failure and he needs dialysis, 1 out of 2 will die in the hospital. So it's one of our tasks to try to avoid this. And how can you avoid it? Well, I've written it down here. left heart bypass with crystalloid perfusion. It was Joe Coselli who showed that crystalloid perfusion of the kidneys is better for the protection than blood perfusion. And of course, another option is the ECC, as I've told you. So, this is what we use. Ringer's lactate, 1 liter. We add mannitol. Mannitol is a strong diuretic, but it's also a free oxygen radical scavenger. And we cool it at 4 degrees. We give 300 cc per kidney at a flow rate of 100 cc per minute for 3 minutes. And then we repeat it after 20 minutes, but the volume is less, 200 instead of 300. How we do it is with roller pumps, 2 separate small roller pumps, and the coronary balloon catheters, like everybody uses it. There are some drawbacks because you get some volume overload. The blood pressure will mostly increase, the drop of the temperature, and of course your kidneys will be warm after a while because they are surrounded by warm adjacent normal tissues. So that's the reason why it's necessary to repeat it after 20-30 minutes. These are my own interpretation of toracoabdominal aortic surgery and tips. Avoid blood loss. We had seen passing by surgeons in the UGN having blood loss. They're all seated, you keep the walls. 50 liters of blood loss. 50. I think you think with me and you agree with me that this is not good for the patient. So try to avoid blood loss. And it starts from the beginning. It starts from the incision of the skin. In the Netherlands, cardiac surgeons opened the skin with the knife until the sternum, because they said it's going to give less infections. But after 5 minutes, they had already 5 gauzes completely wet. I think it's not the way to go in toracoabdominal aortic surgery. It's important to keep the right pleural space closed. We had an opening. This was very difficult to encircle the aorta. I like to encircle the aneurysm because you have to put a clamp on the aorta. You have to be sure that your clamp is completely on the aorta, not 90%, because it will bleed once you open the segment between the So if you can pull on a tape or a vessel loop, it's much easier to put your clamp completely, and then you're sure. But encircling the aorta in the lower thoracic area, you with your fingers, because the pleural space there is very thin, and you can enter the right pleural space without knowing it. And then during the operation, a lot of fluid, blood, may enter into the right pleural space. And then suddenly the anesthesiologist said, there is a problem, I cannot ventilate the right lung anymore. Think about it, that the reason could be that the right lung is full, of the right pleural space is full with blood. And another tip is to keep the peritoneum closed. It certainly costs you more minutes in the beginning to keep it closed, but at the end, the closure is a pleasure, almost. Because in half an hour you can close the patient, otherwise it costs you 1.5 hours, not to say about the fight you have to do with the guts continuously. So clamps properly placed and completely placed, that's the way we do it. Proximal clamp, distal clamp, open the segment, put retraction sutures on the wall, look for intercostals, oversew them, reperfuse eventually, and proceed downwards. It's always the same steps. And in fact, you should not ask, give me, if your scrub nurse is awake and looking not only on her table, but also what's happening in the operative field, she should be able to give you what you need immediately, and you should not ask, you should not have to ask it. So these are the ideal drawings from Joe Coselli with no blood. Although here there's some blood, yeah. Oversewing of intercostal arteries in the proximal part. Avoid the damage of the left recurrent nerve, because hoarseness is not infrequent. I think at least 10 to 15% have afterwards problems with their voice. They cannot cough because they cannot close the vocal cords. They have pulmonary problems. And the main trick to avoid damage is to look to the vagus nerve and to search for the left recurrent. If you really see it, you can avoid putting your stitches. The most crucial part is the back side, where you don't see it. And if the aneurysm is big, the nerve is incorporated into the aneurysmal wall, and it can be very difficult to make a distinction between nervous tissue and aortic wall. We've tried once this instrument that I don't know if you know it, but there is an instrument that it's kind of electromyography of the area right over there with you give electrical stimuli in the area around the aorta, and they look with the electrodes on the vocal cords. So if you are close to the nerve, you see the movement of the vocal cords, and you know for sure that you are close to the nerve. You don't see it, but you know that you're close. So maybe in the future this will have some promising. This is a promising tool. So that's the finishing of the proximal anastomosis. Then you fill the prosthesis, the air, put your clamp, and continue this. This we will never use anymore. We don't make big holes. Davide, you saw it. You make a small hole. If you have 3 pairs, maybe we make 3 small things. No, not so big like that. Small, like this. So the reason why we don't keep aortic wall in these openings is that if it's a connective tissue disorder, it can dilate over time and give a patch aneurysm. So if you want to avoid it, keep your opening small. Again, then proceed downwards. Also here, this is only rarely we will do it in one step. Mostly it's 2 combined and the other 2 separate, or with a separate graft if you want, but it's not necessary. Very easy to encircle the surroundings of the ostia and then to reimplant it into the prosthesis like you see here. This is the most easy case. And then continue downwards. Also this inlay we will never do. We will transect it completely so that you can see the backside, because in this area the danger is the vena cava inferior. You can put your stitches through it, or you put your clamp with the tip in it, and that's again one of the reasons why I like to encircle this area and the aorta. But sometimes when they have already a graft right over there, it's so fibrotic that it's almost impossible to encircle it. And then another trick then is to stop the pump for 2-3 minutes, open the aorta and look from inside. Then you can see, you can transect the aortic wall and not entering the vena cava. So this is then the ideal final situation. I have said already that this interplay is very important, and I'm convinced that this is also true. And this too, but you can read it and think about it. So again, toracoaddominal aortic aneurysm surgery is teamwork, and you have to talk to each other and understand each other. Even you all speak Italian, I try to speak a bit Italian, I try to understand you, you try to understand me. If we don't understand each other, you get this kind of situation. So I think this is my last slide. And I'm willing to answer questions about every topic, because in fact I can go on for a few hours on every specific topic, because it's so overwhelming that there's much more to say than what I've said to you in this, I don't know, 3/4 of an hour, half an hour.
30 minutes, 40 minutes.
48 minutes,
48
48 seconds.
Thank you. Thank you, Mark. I think that we should have a lot of questions for you.
I don't know.
Yeah. First
Thank you.
anesthesiologist.
Thank you for being back again in Bologna. My question is about hemoglobin threshold and fresh frozen plasma transfusion. I mean, there's a lot of debate in cardiac surgery about the hemoglobin level threshold to transfusion. So, which is your approach, and particularly when you note damage on spinal cord and you have to reinsert spinal drainage, which is your hemoglobin level?
If you allow me, I give this question to
Philip,
Philip.
yes.
Yeah, it's not clear cut. There are no guidelines telling you should do it like this. It's like you have a lot of monitors to look at. You have your cerebrospinal oximetry. You have your blood pressure. During surgery, I try to have at least a hemoglobin of 8, but there are people who say you need to have 10, but for short periods of time, I think it can be safe when you have your monitoring, everything is okay, you have no blood pressure, no hemodynamic instability, to go to maybe somewhere around 8. And you know at the end of the procedure, like today, you will get some blood from